Live at the MedTech Conference in Toronto. We're not in Mars, we're in Toronto. I got Brad here, super excited, and I got my co-host Randy. Tell us about yourself, Brad.
Yeah, so I'm Brad. I'm the VP of Quality and Regulatory at a small startup company based in Austin, Texas called Senseye. We're developing a diagnostic test for PTSD, anxiety, and depression using a smartphone.
Cool, awesome. Well, man, I can only imagine the population. I'm already thinking of our vets and others, the different demographics. But what are you working on hard right now with what you're doing?
Yeah, so I think right now, it's a couple things. I think number one, collecting the data to be able to support FDA authorization and regulatory approvals across the world is one piece of it. But I think one of the core missions with Senseye is to bring a level of objectivity to mental health. In most places where PTSD is actually diagnosed, you have like primary care, for instance, where one study, for instance, published showed about a 22% prevalence of PTSD in the population compared to about 9%, from it that you see overall population. So much higher concentration of PTSD in those clinical settings, but yet only 11% of that 22% had the diagnosis in their chart. So we're trying to produce something that is going to be able to be used by clinicians, regardless of their level of training, regardless of their level of expertise in PTSD, to help identify it and get those people into more appropriate treatments.
I love this because one of my first questions really is, how is this impacting patients? And you're like right out of the gate doing that. That's awesome.
Yeah, that's really been the driving force for what we're trying to do. And it definitely is a mission that we all feel. We're about a 22-person company, so we're super small. And that mission is really something that we all kind of feel and buy into.
So you have a large group of undiagnosed or underdiagnosed people out there, with carrying a pretty heavy burden, medically and mental health wise as a result of this. So first, let's talk about what is your actual, what is it you guys have built or are building? And now let's talk about, how do you know if it's good or not? How do you know if you're getting an accurate measurement if these things are so hard to take in the first place? So let's start with this.
Yeah, that's a great question.
What did you actually make?
So the science around PTSD, but also anxiety and depression and other mental health disorders, is that there's specific disruptions that happen in the sympathetic and parasympathetic nervous systems that manifest itself through the eyes. So it changes people's gaze patterns when they look at images. It changes how their pupils react to brightness changes. And those are the type of things that we're picking up on. So we use the front-facing camera of a cell phone to record a person's eyes while they're watching a series of images, and then run that through a machine learning algorithm to produce a diagnostic test result. And our aim there is to try to be akin to like an A1C test or something like that for diabetes, or blood pressure for hypertension.
So smartphone camera, point at the face, and basically the eyes don't lie.
The eyes don't lie.
Okay, there actually is science behind that.
There's science behind that, and it's been documented in published studies on PTSD, but nothing to date has pulled it all together in a multimodal approach. So that's really what we're aiming to get our specificity for PTSD.
So if you're like a psychologist, psychiatrist, or neuropsychologist, you can't just look at the eyes and say 1, 2, 3, score.
And it takes so in the clinical studies, and to your previous question on how we make sure what we're getting is true, is that there's really two standards of care. There's the by the book standard, which is a lengthy clinical interview that takes about 1 to 3 hours and really specific training for clinicians, and that's what we're using in our clinical studies to be able to produce a true baseline diagnosis or ground truth for our device. But then there's the real world on the other side where these tools aren't used. So the book diagnostic tests that we have today just aren't used because clinicians either don't have the expertise, they don't have the time to spend 3 hours with a patient. So that's the gap that we're trying to bridge.
So the science is known. We know how to gather accurate data to make accurate diagnoses. It's just functionally almost impossible to do in today's healthcare system.
Yeah, and people can go to a trauma focused clinician and get a good diagnosis. And treatments for PTSD and anxiety and depression are all well established. They're backed by data and science, so there are good treatments out there. But it's a matter of getting everybody that has the disorder to those clinicians. Because one of the things with PTSD is that you have people that go through 10, 20 years of having the disease, never having it diagnosed. So they end up, suffering because of that, not only for themselves, but also their families, their, personal lives. And also, it's a burden on the healthcare system that doesn't really need to exist, like the costs.
What is, you take the prevalence, what is the prevalence currently, you would say, of PTSD?
Across the whole population, it's about 9%.
In the United States.
In the United States.
And so help me understand, because I think of PTSD as like you've been in a war, but 9%, that's not a war. Like, what are other things that are actually common, causes of PTSD?
So when you look at the overall statistics for PTSD, most of it comes from civilian population. Like when you think of PTSD, naturally you think of war veterans, but and they're definitely a very high prevalence population. But the group that doesn't go to the VA, that probably doesn't see trauma centric patients are out there not getting the help that they need. So any kind of traumatic experience like sexual violence, interpersonal violence, seeing natural disasters, experiencing things like the hurricanes that we just had, all of those things can lead to PTSD. So it's definitely a problem that's not going away, and the tools that we have today right now just don't cut it.
And I'm not really that great at math, but 9%, we're talking like 30 million people in America, maybe 20 to 30 million.
Yeah, it's a large group.
Wow.
So it's funny. Is there someone working on the parallel side to scale PTSD treatment? Because if you double the number of identified people, it's not like we're flush with mental health providers these days.
Yeah, I mean, so that's a big part of the problem. But I think shedding a light on it so people at least know what they have. So when you get a test result, it's something that both a doctor and a patient can look at and say, hey, there's something going on here that is physically or neurologically wrong. Let's get to the core reason and treat it. And on the backside, the treatment and having the healthcare capacity to address that is definitely another piece that has to be addressed. But those people can't even get on a waiting list for treatment if they don't have a diagnosis.
If you don't know that it exists, you can't know that it's a problem. That's really interesting. This wasn't on the list of questions, but we can edit out if it doesn't come out well. But how do you convince? Who are the providers who would prescribe this? And how do you convince them that this is a valid tool, that patients will use it, that they can trust this? Like, what is that for? Because this seems like a pretty big change from going through an hour and a half assessment. I'm interviewing you assessment.
Yeah, I mean, I think it's based on data to back it up, data and science. I mean, that's also what we're doing with FDA as well, is to collect that data to really make sure that we have a high sensitivity and specificity and accuracy in what we're doing to present that to clinicians. But you can also look at they have patients that they're treating right now that they don't know they have PTSD, so maybe the patients need a different sort of treatment that they just don't know that they can't get. And also, if you compare this to a 3-hour interview, a clinician could use this and say, get a lot more patient volume in and not have to spend as much that full time with that patient before being able to determine do they have PTSD or not. So this device can open the door to conversations about trauma, conversations about the root of the problem, rather than touching on the surface and then sending them out the door.
Sounds like important work, as we say. So one last question, because you actually mentioned you came from a good session about bias in AI and the challenge of localization of AI. Like, do I need to overtrain my algorithm, not just for a national population, but for the population in my health system, kind of a thing? So let's do a different angle. You're using a camera to look at the eyes. We've been moving our camera all day because we're under a skylight here, chasing the sun. Bias from sunlight. Like, is that a challenge for you? Like when you're doing it, how do you get control or know that, you're getting a good reading with, infinite possibilities of variation in lighting?
Yeah, I mean, there's going to be certain parameters that need to be met with it. So certain lighting conditions and everything. But with the phones, we're able to detect things like luminance and everything, and know whether a session is going to work with the patient. So we're building those things into the software up front, so that we're able to not spit out an incorrect reading, but to rather assess, is this the right condition? Is this the right setup for a person to use the device?
Okay.
I mean, it's kind of like any devices in hospital settings. It has to be under supervision, under the right conditions.
So patient won't be like on a surfboard in Anaheim,
Exactly,
selfieing on the water with the glistening, sun coming down.
Yeah, and I think that's a distinction with a lot of maybe more wellness type apps compared to medical device applications. I think we're so used to smartphone applications that you can just do on the go or do here and there, but it is a serious test. So I think making sure that that level of understanding, like this is a medical device, this is a test I'm running even though it's on my smartphone. So I want to take it seriously because I want a good result.
Any other sessions you're waiting to see at this conference, or other interesting tidbits to share with people?
I think I'm definitely looking forward to the CDRH town hall and the predetermined change control plan session. I think tomorrow. That's one area with AI and algorithms, and what we're doing is that we want to be able to build in the changes that we know we're going to make, retraining the model, developing on different platforms, things like that. So we want to be able to build those into the product and get that, get FDA on board with those type of things. So, those will definitely be interesting.
We're going to have to get you back on the show because that's a fascinating topic in its own right. But great. Well, thank you. And
yeah, great.
I can say Michael and I and the entire audience out of here is rooting for you guys.
Yeah. Sounds good. Well, thank you very much. It was a
Good
pleasure.
So good to have you on, Brad. Thank you.
Yeah. Thanks a lot. Have